rate will be less steep, will be something like a decline of 3% with the passage of every minute. So we're still going to be having close to like 85% of bringing him back to life, compared to 50% of bringing patient B back to life, just because somebody has been doing CPR. So CPR preserves that shockable rhythm in the shockable phase, so that we consider. Now look at this graph here. Now we're trying to compare the effect of bystander CPR on the chance of survival, and you can see that patients who actually receive bystander CPR will do better with defibrillation than patients without bystander CPR. So the two of them work together. Now this is a study that was carried out again in the United States, and close to 3,000 patients were used. And from here you can see that two things will impact on probability of survival to hospital discharge. They are the time from collapse to defibrillation and the time from collapse to CPR. So let's look at a patient, for example, who collapses and in the first minute received bystander CPR and got shock in the 5th minute. You can see from this graph that its chance of survival, probability of survival, is about 40%, compared to a patient who collapsed and then CPR started maybe in the 1st minute, then defibrillation started only in the 10th minute. Okay, you can see that that chance is reduced. So this is to emphasize the effect of early CPR and early defibrillation on survival, and this is also showing the shock and how the patients respond. Up to this point now, we'll be able to deal with 3 out of the 5 links in the chain of survival. Okay, so we've dealt with skills that will help you identify impending signs of cardiac arrest and make informed decision of calling for help and how to call for help appropriately. You've seen the importance of early defibrillation, which is what will actually stop the abnormal arrhythmia and then help the heart to restart on a good note and start perfusing the whole body. And then we will see the importance of early advanced life support, which is part of what we now want to emphasize a little more. Now, at basic life support level, all you are able to do is to give your effective CPR, which of course will maintain the life of that patient in that form, and we hang the patient. The illustration I make is it prevents the patient from crossing from time to eternity. Okay, so blood is going to vital organs. Even though your high quality CPR at the best will only produce 25%, 20 to 25% of the normal cardiac output of the patient, but that is enough to sustain the patient in that state. Now, if fortunately you are ACLS capable, then your patient has higher chances of survival. For example, ACLS intervention will help you with your ECG. Okay, you may be able to see the specific rhythm that is in the heart of the patient, or in the pre or peri-arrest phase you can have a baseline, the ECG of the patient. That can actually tell you a great deal of what might have been responsible for the cardiac arrest. 12-lead ECG, for example, will tell you a patient with myocardial infarction through ST segment elevation. So you will know that this cardiac arrest actually eventually was due to MI. For example, if your patient has had maybe from the baseline 12-lead ECG we had before, your patient has prolonged QT interval. So that again may be telling you some causes of that, maybe electrolyte imbalance or congenital problems or some other drugs that the patient has been taking is responsible for that. So that helps you to triage effectively and rule out the differentials of the arrest. Okay, now ACLS again, during ACLS intervention you are able to set lines for the patient. So that will help you to deliver some ACLS drugs that can help the patient and probably improve the chance of survival. Okay, so advanced airway management is also part of what your ACLS protocol will enable you to perform on the patient. So if your patient has been receiving CPR just through basic airway before, now you can intubate the patient, and that means that chest compression can go on without interruption, unlike the 30 to 2 that you were doing before. So those are some of the advantages, and then that ACLS intervention enables you to use a manual defibrillator instead of an AED. So manual defibrillator has more extensive use. It can pace, it can cardiovert, and most of them have cardiac monitor. So that is the fourth link in the chain of survival. We must have facility. Every hospital must be ACLS capable. In my personal opinion, I think it's criminal to have a patient who have cardiac arrest in the hospital setting without receiving standardized ACLS protocol. So every patient going to cardiac arrest in our hospitals must receive standard ACLS protocol before we certify them dead. Okay, so that is the fourth link in the chain of survival. Now, what is the fifth link? Before I explain the fifth link, which is integrated post-cardiac arrest care, let me lay a principle. When you are doing CPR, there are goals and expectations. And one of the immediate goals is what we call ROSC, return of spontaneous circulation. Okay? It's one of the immediate things we want to see during CPR. Okay, now because you started chest compression because your patient did not have palpable carotid pulse, which is a central pulse. Now you've done your CPR for 2 minutes, 4 minutes, 6 minutes, and your patient now comes back with a pulse. That means you've achieved ROSC. That's an improvement. Now your patient may still remain comatose. Okay, they may still be unconscious, but now he has palpable pulse. That is a critical phase in the life of that patient, and there are things you should do and you should know how to do. And this set of steps, I think about them that they are so important and they are so often neglected. Okay, this is one of the reasons for justification of this. Cardiac arrest is like ischemia of the whole body, and all of a sudden your patient has ROSC, and that is similar to the perfusion injury. So the free radicals and complements, they will be in the body and they can do a lot of damage, and the organ that is most affected is the brain. So there must be some intervention that we keep the metabolism of the body at suboptimal level, so that the waking heart can meet the requirement, so that those adverse reactions will not have optimized environment to operate. A study found out that 1/3 of patients who die from sudden cardiac arrest die from brain and neurological injury. Another 1/3 of them, they die from myocardial damage. Maybe they suffered extensive damage to the muscle of the heart, and then they cannot recover. Another 1/3 die from various inflammatory responses, and that is what this fifth link in the chain of survival actually seek to attack, which is integrated post-resuscitation care. Now there are a lot of protocols under this, but the most important one is what we call therapeutic hypothermia. Now therapeutic hypothermia is a situation whereby you cool down the core body temperature of a patient who has had ROSC but remains comatose. You are going to cool down the body temperature to between 32 to 34 degrees for 12 to 24 hours. Okay, you cool down the core temperature to between 32 to 34 degrees for 12 to 24 hours. Now that is going to reduce the damaging effect of the inflammatory response on the brain. Okay, and again, that is the point. You want to optimize ventilation for the patient using your pulse oximeter, and that is again the time that you want to perform immediate coronary reperfusion, because if that cardiac arrest has been due to blockade of a coronary vessel, there must be a strategy to reperfuse the heart. And these are some of the things that you do. Another important thing, which is the last thing I want to mention, is what we call neurological prognostication. This is the time at which you calculate the effect of that cardiac arrest on the patient and see whether they can stage a comeback with intact neurological function. This helps us to plan and prioritize limited ICU equipment and know how many of our patients will come back. Now, if we do all of these things and we take responsibility at different level, the government, they take their own responsibility, the society take that, and you as a professional take yours. Many of the patients, we have a chance of saving many of the patients in cardiac arrest as we encounter them in our day-to-day practice. Thank you.